So functional hypothalamic amenorrhea, chronic, it's basically leads to chronic anovulation with associated with excessive exercise, weight loss, or stress, often in combination in the absence of other identified causes. Investigations indicated if the cycle length is greater than 45 days or there has been more than 3 months of amenorrhea. Evaluation includes history and some investigations. So the history should be in the history we should inquire about the dietary pattern, eating disorder like bulimia or anorexia nervosa, exercise, particularly with regards to the amount of exercise, the intensity of exercise, and the frequency of exercise. So all three components like the amount, intensity, and frequency of the exercise should be inquired. Then stress and psychology, we should specifically ask about the perfection, uh, exam related stress and performance anxiety. Drugs, complementary therapy or substance that the patient has been using. Sleep and mood disorders or mood stability, and the sleep pattern is also important. Periods and OCP uses, we should also ask about the oral contraceptive usage in the preceding few months. Features of the organic causes like any history of galacturia, headaches, hirsutism, acne, family history, autoimmune disease, and systemic disease. All of these needs to be inquired. In the endocrine investigations, first of all, we need to talk about the thyroid function test to rule out any hypothyroidism, prolactin, because hyperprolactinemia may lead to amenorrhea, LH, because if it is central, then the functional hypothyroidism, functional amenorrhea leads to less level of LH and FSH, estradiol, which would be low, DHEA sulfate, and 17-OHP to rule out any adrenal causes of amenorrhea, and 17-OH particularly with regards to non-classic congenital adrenal hyperplasia. Exclude pregnancy by doing the pregnancy test, pelvic ultrasound to see if there is any problem with the ovaries or adrenals or the genitourinary structures. Consider MRI, pituitary, and DEXA scan. MRI uh, MRI of the pituitary is done to exclude any pathology in the brain, and DEXA is done to rule out osteoporosis in these patients. So the treatment involves correction of the energy balance, like the intake should be equals to the energy output. Reassurance, it may take 1 year or more of the normal weight and exercise to recover the regular menses. Psychological support is very important, and for that, CBT, cognitive behavior therapy, may be required. And consider short-term estrogen with progesterone. In these patients, if the amenorrhea has been more than 3 months, then it is important to give them oral contraceptive pills so that it could be regularized, and avoid ovulation induction unless the BMI is normal. Ovulation induction should only be attempted when the BMI is within the normal range. So the differential diagnosis of secondary amenorrhea or hypothalamic amenorrhea are pregnancy, menopause or perimenopause, polycystic ovary syndrome, hypothalamic amenorrhea, hyperprolactinemia, hypothyroidism or hyperthyroidism, diabetes mellitus, premature ovarian failure, and anorexia nervosa.